Sorry, give me a moment. Okay, so hi everyone, welcome to the meeting. My name is Dana and I will be one of your intro PowerPoint presenters for today.
Hi everyone, my name is Jenny and I'm also going to be presenting these slides with Dana today.
Okay, so to become a paid member, you first have to fill out the PPS membership Google form, which can be found in our website and email, then pay the membership fee to our Venmo account. Next, you're gonna email Allie to discuss either picking up or shipping your member exclusive t-shirt. It looks like this. Sorry, it's pretty snazzy. Our publicity chair, Christine, designed it. And lastly, you can see your stamp count on our virtual stamp sheet. And keep in mind that you do not have to become a paid member to attend our events, but you will receive a lot of benefits, including the t-shirt, priority to events with limited spots, and so much more.
All right, so before I go into this week's topic, I want to briefly talk about what the pharmacy topic of the week is. So the purpose of this is to educate you all on the field of pharmacy a bit more than what you're already exposed to. And this will be alternating every other week with the PTCE topic of the week, and this will be throughout the whole school year. This week, we're going to be talking about SB 493. The bill was passed in 2013, and I know this isn't necessarily current or recent, but I still think it's very important for all of us to know about this because it is a milestone, I would say. So to summarize this bill, it declares pharmacists as providers. It allows them to provide more clinical services like prescribing hormonal contraceptives like birth control, or also providing nicotine replacement therapies like the patch or the gum. It also established the advanced practice pharmacist recognition, which allows those pharmacists to perform patient assessments, order drug tests, and also adjust drug therapies for patients. But this does have to be done under specific circumstances with agreements with treating prescribers. This is an important bill because it allows pharmacists to play a larger role in healthcare teams. Pharmacists are pretty accessible, so it's beneficial for the patient because it's more convenient for them to get these things from the pharmacist, and also helps the doctors by saving them some time, or the prescribers. And it's important for the public to know more about what pharmacists do because I believe they are a bit under-recognized and underappreciated by the public. We would like to thank you all for coming to our first general meeting that we had last week. Here are some pictures from our meeting where we were in breakout rooms and we were doing group poses. Some of them you may be able to tell what they are, but I think everyone did a great job. We hope you all had fun despite the technical difficulties, and we'd like to thank our social chairs for hosting our social games and also our after social.
Okay, so moving on to our upcoming events, we have our week 3 general meeting next Wednesday, October 21st from 6 to 7 p.m. with the same Zoom link. Dr. Micah Hada, who is a professor at Western University College of Pharmacy, will be presenting his perspective on the outlook of the pharmacy profession. So if you're interested, you can go ahead and click on the Zoom link, and if you are a paid member, you will receive a stamp for attending. And if anyone has any questions, comments, or concerns about the meeting, you can feel free to contact me.
A volunteering opportunity we'd like to bring attention to is the Be My Eyes application. This is an app you can download on your smartphone, and the purpose of this app is to help those that are visually impaired with some simple daily tasks. You can do this whenever you choose to. It's not like a event that you have to come to at a certain time. It's an app that you download on your phone, and if someone does need help, it will ring your phone and 9 other people. And if you are available, you would pick up and help that person with the task. I heard that some examples are perhaps telling someone what the expiration date is on their food, or also telling them the color of one of their articles of clothing if they're trying to pick an outfit. Unfortunately, I haven't been able to pick one up. I've been called twice, but I was working and then in class. But I hope that you all that choose to participate get the opportunity to help them. I think it's a great opportunity for us to volunteer our time, even though it is virtual, and you can use an ability of yours to help others that may not have that ability. If you are interested, you can download the free app. It's offered on iPhones and Androids. And if you are a paid member, you can receive a stamp by filling out the Google form, and you can send me a screenshot of your account by October 21st by midnight in order to receive the stamp. If you have any questions, comments, or concerns, you can contact me at my email. Now I'd like to invite Ali to talk about our Western U virtual visit.
Hi everyone. So another upcoming event that we have is our Western U virtual visit. It will be taking place on Saturday, October 31st from 10 a.m. to 12:30 p.m. and a Zoom link will be sent out to those who are interested in attending. While we may be limited to our physical interactions during this period of time, that doesn't mean that we can't still connect and learn with each other. If you are interested in learning more about Western U's PharmD program, this is a really great opportunity for you to get all of your questions answered while in the comfort of your own home. It's always truly a pleasure each time we collaborate with Western U, so please look forward to hearing from a panel consisting of both alumni and current students and some faculty with different areas of expertise. Your feedback in terms of what type of pharmacy you'd be interested in would be much appreciated in tailoring our virtual session to you. If you are interested in attending, please complete our interest form by 11:59 p.m. on Wednesday, October 28th. And you can find this form on the slides or in our emails. Moreover, paid members will be receiving a stamp for attendance, so yay. If you have any questions, please feel free to contact me at my email provided on this slide, millsac@uci.edu. Thank you, and I hope to see you there. Also, an upcoming opportunity that we have for you guys is our board intern program. So this is a really cool opportunity that is extended to any interested paid member who wants to gain leadership experience. So this program allows interns to observe the inner workings of our PPS board, contribute to the planning and participating in our major PPS events, and you can also gain interview experience. I'm sorry. If any of these items are something that stimulates your interest, I highly encourage you to apply. What better time to build your social network than right now, right? You can find the application in our upcoming email being sent this Sunday, along with more details, so please look out for that. And with that being said, if you have any questions about the program, please don't hesitate to reach out and contact me. Thank you.
Thank you, Ali. Now we'll have Tyler, our ambassador, talk about Pre-Pharmacy Day.
Oh, I pressed the wrong button. Hello, everyone. I just want to talk about our upcoming event, Pre-Pharmacy Day. And I say upcoming very loosely as it is taking place winter quarter in January, but I kind of want to take this time just to introduce it to you guys for those who don't know. PPD, or Pre-Pharmacy Day, is one of our largest events of the year. And this is an event where many school representatives as well as pharmacy school students take their time and talk to us students, our prospective pharmacy students, during the day, get your questions answered, as well as they host panels and workshops for you guys. So this, like I mentioned, is going to take place Saturday, January 16th in winter quarter, and it will be located on Zoom. Why you should attend is really just to get a jump start in your application process, as well as finding a little more about the field of pharmacy in your dream school. If you are interested, please fill out the Google form again by January 9th at 11:59 p.m. And if you have any further questions, please contact me at my email right here. I just also want to know, to let you guys know that starting next week, you should be also getting the Google form sign up in our emails, and feel free to keep updated on our website, prepharmacyday@uci.com.
Thank you, Tyler. Now I would like to show our platforms. So we have a Facebook, Instagram website, Discord server, and a Zoom study room. These are all available at the end or at the bottom of our most recent email that we sent out if you all would like to stay connected with us on those platforms.
Okay, now introducing our guest speakers of the week, Dr. Mark Baje and Ms. Janelle Agustin.
Hi, everyone. I'll go ahead and share my screen right now. Okay, I trust that you all can see my slides, and thank you so much for inviting me again. You know, coming to the Pre-Farm Society is always something I look forward to because I've been impressed every year that I've come with respect to how organized you guys are and how proactive, how very active you are with your activities, your level of involvement. It's going to serve you well as you apply to pharmacy school. So no, very impressive organization, and thank you again for allowing me to join you this evening. Undoubtedly, some of you have probably heard me speak in years past, and a lot of what I'm going over still will kind of cover a lot of those topics that I had gone over previously, but I think nonetheless, I still think it serves as a way for you to continue to understand what it is that pharmacists do on the inpatient side. So just to introduce myself briefly, I am currently the clinical coordinator of the Department of Pharmacy here at the Medical Center. Essentially what that means is essentially I'm coordinating all the clinical activities that we do here. So I have a number of specialists that I oversee, and any and all activities that they are involved with at the Medical Center are largely guided and I support and ensure that we are able to be very involved throughout the Medical Center through various clinical initiatives. Another particular area that I cover is heading the Pharmacy and Therapeutics Committee, and so that entails consideration of all the drugs that we use at the Medical Center, drugs that we approve for use, drugs that we don't approve for use. So all that stuff is tightly looked at by this committee. But for the last 18 years, I was actually in the critical care realm. So I served as a critical care specialist for the past 18 years in the surgical ICU here. I also serve currently as a residency program director. So for those of you that are looking forward to life beyond pharmacy school, then undoubtedly our paths will cross at some point when it comes time for you to choose a residency program. So for this presentation today, again, my goal is really, again, to give you an insight as to what it is that clinical pharmacists do here on the inpatient side. You guys all know full well that pharmacists are involved in many different areas of pharmacy. So I'm just giving you a glimpse of maybe what the hospital pharmacist does. And I do so from the viewpoint of what I used to do as a clinical specialist and now as clinical coordinator here. But this year I've added an additional guest. We have one of my pharmacy students, Janelle Agustin, who will give you a little bit of insight as to her pathway into pharmacy school from UCI and ultimately where she's headed, which is a future in the inpatient pharmacy setting. So toward the end of this presentation, she will be able to give you a little bit of kind of her view of things. I'm going to go ahead and open up the floor to anybody who is willing to put themselves out there. But some of you, again, I know you've seen this presentation before, so I should definitely hear from a number of you. What is it that you think that inpatient pharmacists do? I'd love to hear some feedback from anybody out there. Nobody's willing.
They work within the healthcare team to make optimized solutions for patients' treatments.
Very good, and nice to see you, Christy.
Hello.
Anybody else? All right, it's early in the year, and this is your first meeting, so, you know, I understand people are going to be a little shy. Let's go and just get into it, and hopefully by the time the end of this presentation, you guys will have the ability to verbalize what it is that inpatient pharmacists do. And again, this is not a comprehensive inventory of what we do, but just a snapshot. Ultimately, it comes down to making sure that we have the right drug at the right dose, route, frequency, duration, and the right monitoring this is not anything unique to the inpatient setting. This is what pharmacists do, whether you're in a retail setting, in the ambulatory care setting, or in the inpatient setting. Don't lose sight of what your primary focus is. And oftentimes I see students wanting to come into the inpatient setting and approach it as if they're one of the physicians, and they're not focused in on really what the core part of what pharmacy does. And we do so in the context of this kind of, let me go ahead and just fix this here. In the context of the medication use process, which involves the ordering of drugs, the dispensing of drugs from pharmacy, and ultimately the administration and monitoring. So all of our activities kind of circle around this. Without this, there is no pharmacy services at UCI. So again, though I'm now in kind of a more administrative realm, a lot of what I do focuses around this process. And so we will see here a collection of activities that contribute to this medication use process. So again, I'm just going to kind of walk you guys down in terms of some of the things that I used to see as the critical care specialist, and I'll give you a sense of what it is that we encounter. So we are involved in the direct management of drug therapy. So there is an example of a patient admitted for multiple trauma, secondary to a motor vehicle accident, and while in the hospital, they develop a life-threatening clot, in this case in their lungs, called pulmonary embolism. So a physician then orders heparin IV per pharmacy. So this is essentially the physician saying, pharmacy, I need you to manage this patient. I need you to try to get this patient's blood thin enough and keep it there so that the clot does not extend. So this involves pharmacy in entering, doing an initial assessment, entering orders, and starting the therapy, giving the starting rate, and managing the rate of heparin that we give based on the lab results that we order and monitor. So we do this in collaboration with nursing, and there's lots of communication with physicians. We write notes in the chart, and we are in charge of managing that patient, which is a great deal of responsibility. So you'll often hear of per pharmacy protocols, and this is what we're talking about. A physician saying, we want you to manage the heparin per pharmacy, or the vancomycin per pharmacy, TPN per pharmacy. So we start the heparin per pharmacy, and then 6 hours later, we're monitoring a lab value called an APTT, and the lab value comes back greater than 200, which is a huge number. Our goal is 65 to 90. And so one might think, oh, we must have done something wrong. But the expectation here is that no, there must be something that might have contributed to this. So part of what we need to do as pharmacists is investigate lab values that we don't expect. Because certainly when we start, we don't expect it to be off the charts high. And what you'll come to see later on is the importance of medication safety. And when things don't happen, there might have been a mistake that occurred. And we need to troubleshoot lest we misinterpret this number and then do something inappropriate in the opposite direction as a reaction. So pharmacists on the inpatient side managing drug therapies under protocols that have been approved by the medical center. Our specialists are also involved in guiding therapeutic choices, as you can imagine. So in this case, a 42-year-old male involved in a motor vehicle accident develops septic shock in the ICU, is started on IV fluids, and then we start a drug called norepinephrine to try to support the blood pressure. And they titrate it to a maximum rate in this case. But it doesn't seem to be working. The blood pressure continues to be low, and a physician wants to start vasopressin. So they might then put an order in, and we're going to have to decide, is this the right drug to start? Yeah, is this, is there a reason why the norepinephrine is not working? And we would then potentially support the use of vasopressin, but also take into account there might be other drugs that we could use that might be not as expensive. Vasopressin is a very expensive drug, a very effective agent nonetheless. It's supported by the guidelines, in which case we might support this, but part of our job is guiding the therapeutic choices. So maybe the norepinephrine wasn't working, and maybe we are the ones who are suggesting, you know what, maybe we should start vasopressin. So providing therapeutic choices and guiding the physicians. In this case, epinephrine is started, but after we kind of turned up the infusion up to its maximum rate, the blood pressure continues to be low. And again, this is where the pharmacist is kind of like, well, what's wrong with my drug? These should be working. The epinephrine is supposed to work. In which case, we might have to troubleshoot. Maybe, again, a medication safety is an issue here. Maybe they started at the wrong rate, and maybe the infusion is not running as it's supposed to be. So troubleshooting and making sure that, and if everything was going all right in this case, then maybe we then kind of go down the route of thinking about adding steroids to help support the blood pressure. Here's another situation where we monitor drug levels. So in this case, we have a female who's got kidney dysfunction. Her kidneys are not working. It's end-stage renal disease, and is admitted and started on a drug to help prevent seizures. And we order a drug level, and it comes back what looks to be normal because it's 15.6, and we want it to be between 10 and 20. However, the patient has showing signs of toxicity. And so this is a case where we need to help kind of instruct the physicians on the interpretation of this number, that in the setting of a low albumin level, for instance, this number is not 15, it actually is closer to 30, which is dangerously high. So interpretation of drug levels is another important function of what we do as pharmacists. Troubleshooting. So in this case, we have a patient treated for a pneumonia on a very effective broad spectrum antibiotic. It's been 5 days now, doesn't seem to be improving. So again, this is where pharmacists, as we teach my students and residents, we tell them, what's wrong with your drug? What's wrong with my drug? Why isn't it working? Okay, and this is where we kind of go right down the list and we say, do I have the right drug? Do I have the right dose? Are they getting it every 6 hours? Have they been getting it for 5 days? And maybe we need to add another drug, or maybe our culture results come back and maybe this drug is ineffective against that bacteria. So, in this case, monitoring therapy and then trying to figure out what's wrong. Why isn't our drug working the way that we had hoped? These are part of what the pharmacists do. Here's a very relevant one. The COVID-19 pandemic has broken out. And yes, this past March, when kind of things went down, was a very difficult time here, and a lot of activity in terms of what do we do? What do we do at the medical center? What do we do as pharmacists? And so here's a listing of the kinds of questions that came up that we had to address and do so very quickly. So there are these inhalation therapies that are given by a device called a nebulizer, and it aerosolizes drugs that help patients breathe. But if a patient's COVID positive, is it safe to actually administer that and have potentially virus aerosolized into a room? So we had to pass policies and get education out that only certain patients could receive these therapies, and certain patients who could not get these therapies, we would use the metered dose inhalers instead. What drugs do we need for these patients? So we had to very quickly identify, which drugs do we need to begin stocking up on? Which drugs are even available to us. When this first started out, remdesivir is not something that was available and only became available after a few months. And so ultimately it was a lot of supportive care that we were doing. We were kind of going blindly in terms of just supporting these patients with drugs to help them in their respiratory status. But, we were still kind of at a point where we didn't really know what would be useful. What happens if we have to treat a critically ill patient in a non-ICU area was another question. Having to plan for stocking drugs in these areas. How do we involve training of nurses who aren't used to treating critically ill patients? What kind of guidelines could we provide for them? So lots of activity in the area. Thankfully, we never had to do that, but it was one of those where we had to try to plan ahead for this. How do we secure key drugs for COVID? So there was drug shortages happening. And we were questioning, are we going to run out of critically important drugs? Securing key drugs. So when hydroxychloroquine was kind of the novel agent at the time, and we were putting it and locking it up and making sure that we accounted for every dose because of fears that nursing staff would take the drug or, begin to hoard the drug. But a lot of institutions began kind of loading up on a lot of different drugs. And so we were wondering about whether our drug supply was actually even going to hold up through this. And so we had to develop a situation where we were ordering lots and lots of drugs and trying to keep as much as we could on hand because of the increasing number of patients we were seeing here. And what happens if there's a cardiac emergency or a code blue for one of these COVID patients where you have to do CPR on them? Do we rush in the room? And if so, are we going to be dressed in PPE? And what if we run out of drug? And, so we had to create a system where the pharmacists had to, deliver the meds from outside the room and make sure that there was a backup tray in case that tray went up into the room. If a drug went into the room, we did not want that to come back to the pharmacy. So we had to create a policy where all those drugs would be disposed of in the room. So lots of different questions that pharmacy had to address on the inpatient side. Here's one where educating the nursing staff. So a physician orders a dexmedetomidine infusion, and the nurse calls and says that she's never used this drug before. What is this? In which case we have to go and kind of explain to them that it's similar to another drug that they're very familiar with. It's given as a continuous infusion. So there's lots of drugs out there that we get questions for, both from nurses and doctors, other disciplines for that matter as well. Optimizing orders. So, patients who get put on a ventilator, one of the drugs that is often used, especially in these COVID patients, is to paralyze them, to be able to optimize their breathing on the ventilator. So in this case, a physician orders a vecuronium infusion, a drug intended to paralyze the patient. But, the pharmacist here might then think, before we actually paralyze them, we need to make sure that there is enough pain meds on board so that they don't experience pain while they're paralyzed, because they won't be able to tell you if they're in pain, and be adequately sedated and make sure they have eye drops in their eyes so they don't get corneal abrasions. So it's not just reacting to the vecuronium order, it's making sure that other important medications might need to be taken into account so as to ensure that these patients could be paralyzed safely. The unexpected emergency. So you're working and then all of a sudden overhead you hear code blue, 7th floor in the medical ICU. So we literally drop what we're doing and we run to the medical emergency and provide support. And sometimes I even have the students or residents go in there and do chest compressions when the nurses are, when there's a shortage of nurses that can help, and they need to, doing chest compressions is quite tiring. So I've had resident students go in there and actually do chest compressions. But obviously providing meds, whatever they need for that code emergency, the pharmacists and the inpatient side are responsible for them. Educating providers. Now this is kind of a unique situation. So you've got, in this case, a male patient who just had abdominal surgery, and then after 2 days of a blood thinning medication called enoxaparin, their platelet count suddenly drops. It's decreased to 100, less than 100,000, and normally it's 150,000 or higher. And the physicians in this case suspect that there's a process going on which we call heparin-induced thrombocytopenia, and maybe they're contemplating the use of a drug that's used for heparin-induced thrombocytopenia called argatroban. But educating providers that maybe this is not the role for a drug like argatroban, that maybe this is not actually heparin-induced thrombocytopenia. Without getting into too much detail, there are certain criteria that kind of lead people to think that this might be heparin-induced thrombocytopenia, in which case using a powerful drug like argatroban to anticoagulate them or to make their blood thin would be appropriate. But you don't want to start this drug if they don't need it. And so this is a situation where a pharmacist is actually commenting on a diagnosis, as opposed to commenting on the appropriateness of a drug. In this case, they're commenting on a diagnosis based on an adverse drug event, known to a drug like enoxaparin. So this is a situation where pharmacists can play a role that you might not expect. And we talked about med safety before. That med safety is everything in the hospital. Unfortunately, not everything goes perfect in a hospital, and there's lots of misadventures that can happen. And here's some examples of things that have happened in the past. Medications was infusing onto the floor. And these are from actual incident reports that have been filed. The medication was infusing onto the floor. The blood sugar was extremely low, 54. We had duplicate potassium orders entered by 2 different physicians for the same patient. The wrong weight was entered for a patient. The wrong concentration of drug was hanging. My pump can't deliver anything lower than, in this case, 0.5 ml per hour. Or we want to thin somebody's blood with heparin, and somebody has a catheter in their spinal cord, which puts at risk for developing, what we call a hematoma. So lots of things that happen and that pharmacists are involved with. These are medication-related misadventures that we have to investigate and figure out ways to make it safer. And thankfully, here at UCI, we're actually have gotten a lot of accolades for our programs for patient safety, in particular for medication safety. So know that at least here at UCI, we have a very robust medication safety program. And not entirely due to COVID. In general, we're always looking for ways to save on costs. You know, we don't have unlimited amounts of money to be able to use all these drugs. And so we embark on lots of different initiatives to try to design it to save money. And here are just some examples of things that we do. But, you know, this is to ensure the viability of this medical center. We have to ensure that we are using our drugs as optimally as possible, and, you know, reserving high cost drugs and reserving them for when they absolutely need to be used, and minimizing it when it doesn't. So this is something that pharmacists often find themselves, especially those who are specialists or in administration. Cost savings is huge. And then as part of cost savings, controlling the formulary. So the formulary is just a list of drugs that the hospital kind of says that this is what we're going to carry and this is what you're going to be allowed to use. And this is an instance where a patient arrives to the ICU and the physician orders a drug called IV acetaminophen, so injectable Tylenol. To you and me, it doesn't sound like very much, but for someone like Janelle, who's my student on the call here today, she understands that there are lots of cost issues associated with this drug. And so, you know, you say IV acetaminophen in a hospital pharmacy, and you're going to get a lot of kind of leadership that's kind of looking like, oh, you know, it makes them worried because, you know, it's a drug that we're trying to control. So we have restrictions on when you can use this drug and when you should switch to an oral acetaminophen instead. This slide always makes me nervous. So, you know, I've moved on from being a critical care specialist into a clinical coordinator. And so my role here at the medical center is adopted much more of an administrative role. And I have lots of people that report to me. And so my days, this is a copy of my schedule. And in fact, the one right in the middle is today. And you can see it's just filled with, you know, almost every hour is covered with some meeting or some task to do. And so this is the new side of my career, which is now much more administrative in nature. And so, yes, you can, you know, look forward to you know, becoming a pharmacist and being very clinically oriented, but there's lots of opportunities for those of you that are more leadership minded or more organizationally, administratively savvy. Those of you that have IT skills. There's lots of, you know, focused areas within pharmacy that don't involve patient care. So know that there's lots of opportunities for you in the inpatient side, and getting to know where those opportunities are is part of what your experience will be as a student. And here's probably one of the more important parts about my job that I really love, which involves precepting students. And so I get this email. Hello, Dr. Baje, good afternoon. I hope all is well. I'm excited to start my rotation with you this Monday, and I wanted to check in on what time you'd like me to come in. And so I precept students, I administer the residency program, I precept residents, and any pharmacist who precepts will tell you that it's probably the most enjoyable part of their job, to be able to kind of, you know, bring in the next crop of, you know, pharmacists and guide them and be their mentor. In which case, Janelle Agustin is my current student right now. This is her third week with me on what I call the clinical leadership rotation. And at this point, I'd like to bring her in to share with you her kind of viewpoint of inpatient pharmacy from the standpoint of a student coming through who's aspiring to kind of get into the inpatient side. So Janelle, I'll have you take it away.
Thank you so much, Dr. Baje. So hi, everyone. My name is Janelle Agustin. I'm a fourth-year student pharmacist at UC San Francisco, so I am last of the four-year program. So I will just, first of all, start off with like just my journey to pharmacy. And as you can tell from the slide, it's not as linear compared to maybe some of your upperclassmen friends who are already in pharmacy school. So I did graduate from UCI back in 2015 with a public health sciences major. What was it? And then I actually took 2 gap years. So during this time, I took time to work, or I continued my job as like a community tech or pharmacy tech. And then I got to explore more things that I feel like I didn't have the time for, because at UCI, I felt like I was constantly like involved with my leadership roles and constantly busy with with school. So in addition to being a pharmacy tech, I was able to work as like a tutor for veteran students. I was able also to be like a camp counselor for a girls STEM program. So it was a really great time for me to really reflect on what I want to grow or to do going forward, as well as still be able to try things that I feel like I just wanted to make sure that when I did decide to choose pharmacy, like this is what I wanted to do. In addition to this, I continued my undergrad research during this time, and we were able to publish a manuscript, which is really awesome and really contributes to my interest also in research. And also during this time, I took some community college classes because, again, I graduated in 2015, and I believe my final year is when they first introduced anatomy class at UCI. So that was, again, a very popular class. So I just took it during at community college, as well as because I had more time, I decided to take Spanish for fun, because I think the last time I took Spanish was back in high school. So again, just taking this time to really develop myself for me to very much prepare for a doctorate level school. And so, as you all know, that I'm at UC San Francisco, but when I was applying, I ended up applying to a total of 10 schools. I didn't finish 2 supplemental applications because as I was looking more into the school, I realized okay, I feel like this school just isn't for me. And then of the 8, I got 4 interviews, and I actually got waitlisted at UC San Francisco. And thankfully I got in, and honestly, it was the best decision to come up here because it was, for myself, I'm from SoCal. So it was a really hard decision as to did I want to leave SoCal? Did I want to be far from my family? Did I want to be far from my relationship? And things just work out, and I absolutely do not regret this decision because I feel like I've grown so much at UCSF, and it's a great program. Amongst all the other pharmacy schools are really great, don't get me wrong. And in the following slides, I'll definitely talk about my journey as to learning more about hospital pharmacy. And as a student finishing her last year in school, I am applying for PGY1 acute care residencies, which are due this December, which I think is super scary, but super exciting at the same time because applications, I promise you, they do not end after pharmacy school applications. So that is my current immediate goal, as to continue to pursue postgraduate trainings in that. So with the next slide. So this is just, again, my personal journey. As you're in this club, or again, know more people in pharmacy, everyone has their own specific journey. So with me, again, my goal is I want to be a clinical inpatient pharmacist. And how I was able to gather that is that I've had, I don't even know how long, maybe 3 or 4 or 5 years of community pharmacy tech background. So I felt medications weren't too, they weren't different to me. And so coming into pharmacy school, I wasn't sure as to well, what fields of pharmacy do I want to be in, because there's so many out there. So first of which, after getting to pharmacy school, is I wanted to be involved in school. And though there aren't as many clubs at pharmacy school levels compared an undergrad, it's more segued into the different fields of pharmacy. And what the one that I had the most affinity for was this first one here called California Society of Health Systems Pharmacists, CSHP. I won't get into the nitty gritties of all these different organizations, but everything that they were doing resonated with me as to highlighting the role of a health system pharmacist, of a clinical role. And as you can see in my other involvements, I still involved in other clubs as well, because I didn't want to be so siloed into one thing, but I still wanted to be, or keep an open mind as to wherever the pharmacy journey takes me. Which leads me on to next thing is during my time at UCSF is that I had an internship position at UCSF Health Medical Center. So this is different. When you're in pharmacy school, you still do your introductory rotations. For this one, it was a paid position where I worked every weekend. And honestly, that was the highlight of my pharmacy school career. And I think that's really what led me to want to pursue a clinical pharmacy path. So I really got to be immersed into hospital pharmacy, where I was able to fill the unit dose machines or compound IV medications. And what was great about this this internship too, is I was able to do dabble into this clinical pharmacist role already. So I was able to monitor like vancomycin levels already. What else? Like I wasn't able to verify orders, but I was at least like watching that process as well, like gaining, or what's the term? Like really creating that foundation of a clinical decision making. And as long as like I was able to get more research opportunities and leadership opportunities too, leading on to my next thing, so research. I did have some exposure in undergrad, and then I think the second I got into pharmacy school, I started to think, okay, well, what am I interested in? And honestly, I really still didn't know what I was interested in, but I was able to at least reach out to the people out there as to like, hey, like this, something sounded interesting, like is it possible for me to be part of these projects? So some things that you can see here is that I was able to help with medication reconciliation, like a pediatric emergency department. The early versus late restart of a cybertrophic home medications I thought was really great, because that was my really like foot into like critical care pharmacy, because I felt like, okay, I've gotten a sense of as to what hospital pharmacy is, but now let's go into the specialties of pharmacy. And speaking of which, actually, I just got an email like half an hour ago that our paper also just got accepted. So this is a pretty happy time right now. And then also too, just pharmacy school, we do have a research project, or at UCSF, we do have a research project embedded into the program. So right now, my team and I, what we're doing is we're assessing Senate Bill 1254, which is required our medication reconciliations in hospitals greater than 100 beds, and to see like how it's helped or maybe just changed opioid prescriptions we've given with the opioid pandemic. Next, we'll go into leadership. So again, you can see here I'm very involved, and that's just me as a personality. I just love to be involved into like a lot of different things. So like, again, while I was there, I was like lead intern at my internship, like holding all these different leadership opportunities. And even though I'm on rotations now, I'm still holding like a leadership position with an Orange County pharmacist group, which is really great. And I'm helping with a lot of different events there, such as, again, myself, I want to, or I'm very interested in pursuing a PGY1 acute care residency. So I'm helping out with their like residency event that we have going on next month. Before I jump into rotations, actually, another thing I want to bring in is that I also did a lot of shadowing too, because I wanted to make sure like, okay, if there's something I don't like in pharmacy, like I want to at least see it before like I commit myself to it blindly. So during my first 3 years while I was in San Francisco, is that we have a lot of like guest speakers that come in, and just like really like getting out of that comfort zone of like, oh, there's just a speaker that just speaks and goes away. Like for me to reach out to them and be like, hey, would it be possible for me to like shadow you for a day to see what you do? Which leads me next on to my rotations. So after all this experience that you see here, I really like started to love acute care pharmacy, and it's really impacted how I ranked my rotations. So I took more of an acute care, I took an acute care path. And so far with that, like acute care settings, I already had my general medicine rotation out at Arrowhead Regional in Colton. And so it was actually quite an interesting experience, because given the pandemic, there's a lot of things that we don't know, which is terrifying, but also really exciting. So just for me to have like, to track the pharmacotherapy of my patients who have COVID, and just literally watch them like 2 days, like being like generally okay. And then one day their O2 stat like drops like crazy. And then they're in this very critical state. Another thing too, is that with this, I was able to help, pharmacists are like the drug experts, and we're hearing all these things about COVID drugs, from remdesivir, dexamethasone, or this Regeneron like cocktail, all this stuff, but who really like knows about this? And pharmacists, like we know about drugs already. So with this, I was also able to like create like a suggestive anticoagulation algorithm for COVID patients. And even now with my clinical leadership rotation with Dr. Baje, it's very administrative, but it still involves a lot of like critical thinking and like knowing your clinical or your pharmacy knowledge. And as much as like I talk about this, and maybe something's maybe going over your head, like once you're really in it or get a sense as to what it is, like you do have like a really great appreciation for this. And then we'll go into the next one. So this is just a snapshot of what my pharmacy rotation schedule is. To note that it's at UCSF, we actually have 8 rotations, but due to the pandemic, some things occurred and it's now been dropped from 8 to 6, but the next classes will be going back to 8 again. And so again, I took a acute care focus where I have my general medicine, and then I have surgical ICU next, as well as infectious diseases. We also do still have like a core, or 4 core rotations that we still have to understand for just for general pharmacy. So like your community, hospital operations, ambulatory care, and general medicine. We do have, well, it used to be 4 electives, but now it's 2, and I still took the direct or patient care approach, in which I'm really excited about to really grow my, again, that clinical decision making going forward as I prepare for pharmacy school applications.
Thank you, Janelle. Just a few more slides here. I know we're up against it. These are just some examples of some of the committees that I've been involved with and some of the protocols and guidelines that I've helped to develop, as well as some of the things that I did with respect to preceptoring. So lots of opportunities. Aside from patient care, there's lots of things that impact how we deliver care, and the things behind the scenes that contribute to patient care in all these forms here. So again, lots of things to be involved with. In short, again, the medication use process is really the backbone for all these activities that we're doing. Ultimately, again, we're still trying to ensure that the medication process, the medication use process is intact, and that we affect this process from the beginning to the end, in some cases more globally across all this. Hopefully this gives you a sense that, you know, hospital pharmacists, it's not just about dispensing medications. So in summary, inpatient practice encompasses just more than dispensing product. We're involved in a wide variety of areas, both clinically and administratively. Yes, we do participate in direct patient care, improve outcomes, prevent adverse effects, ensure the safety of the medication use process is paramount. Multidisciplinary work environment, working directly with physicians, nurses, other disciplines, and obviously opportunities to teach students and residents. Janelle and I have provided our email addresses for you here, and we invite you to go ahead and reach out to us if you have any questions. Again, this is not intended to be entirely comprehensive for all the things that we do, but just a snapshot, one person's view, in this case, a very unique insight by way of my role as a clinical specialist in the ICU setting, as well as clinical coordinator. And hopefully you guys will find your passion in pharmacy. It doesn't have to be inpatient, but you know, as Janelle had found her way, which appears to be leading toward the inpatient side, you may find your path finding, you know, leading you elsewhere. Maybe it's in academia, maybe it's in industry, maybe it's ambulatory care. Be open to it, because there'll be lots of opportunities available to you. So again, just one aspect of pharmacy, but there's definitely lots more available. At this point, I'll go ahead and open up for any questions that people have. And Dana, I'll just lean on you for knowing when we are done time-wise. So happy to stay afterward if anyone has any questions.
Okay, so I actually have a question from a student who had to leave, but he asked, what's the job outlook like for inpatient pharmacists?
Well, lately it's been a little bit challenging because of the pandemic, but oftentimes you'll find that even in challenging situations like this, that there are bold moves that medical centers make. I've grown increasingly optimistic here at UCI specifically. The leadership here has shown a strong commitment to the workforce here, and we've been able to dodge significant layoffs. And not only that, they seem to be, you know, still providing for us, and we feel incredibly blessed. So, but we know that's not the case across the other institutions. So perhaps a question like this being asked now might not be the most optimistic time across all pharmacy departments, but nonetheless, the opportunities are growing. And in this case, I think some particular areas are especially growing just in terms of opportunities. Oncology, for instance, and ambulatory care are 2 areas that come to mind. And that'll change over time too.
Okay, go ahead. You can go first.
Okay, so from my curiosity, is the inpatient pharmacist is more like generalized. For example, it's like if you become oncology pharmacist or pediatric pharmacist that who works in hospital, would they do the same thing that inpatient pharmacy do?
Pretty much. Again, you've got varying levels of pharmacists. So you have, like, let's say, pharmacists who are more focused on the operational, so getting the drugs out, making sure that the orders get verified. You have some that are more clinically focused in terms of rounding, providing direct clinical support to teams, and that would be the situation for your examples of oncology or pediatric. You have some that are more administrative and supporting from a departmental standpoint. These are all different versions of inpatient pharmacy. So depending on your area of expertise or your area of interest, you'll find yourself in one of these areas, and there's lots of different areas of specialty, not just limited to those examples. But no, we consider them inpatient because they will provide for their, making sure that the meds in their areas are taken care of. And oncology, that's extremely important because of the complexity of the chemotherapies and the regimens that they're on. So they're no different. Bottom line, remember I told you at the very beginning, the right drug, the right dose, the right frequency, the right route, that's all common to everybody. And again, that's not just inpatient, but that's retail as well.
I just had a question about the general lab requirement for most pharmacy schools. I know that UCI doesn't have general lab laboratories that come with the general bio courses. So how can we fulfill that requirement, especially if you're not like a pharm sci major?
Yeah, good question. I can't speak to current admission practices. Maybe Janelle can offer her insight. My pathway didn't, in graduating from UCLA, I didn't have all the requirements to get into UCSF. And so there were a couple of years there where I took extension classes in order to fulfill anything that was deficient in my application. And ultimately, that gave me additional opportunities to prove my ability, my candidacy to get into school. So maybe that holds true today, where if you don't have all the requirements, that you may have to still fulfill them. Certainly, if the school requires it, then you're gonna have to find a way to complete it, in which case it's not uncommon for people to be taking extension classes, at the end of the day or the beginning of the day, or, throughout the day. But if they require something that you don't have, then you're gonna have to find a way to fulfill it. Otherwise, you'll have to find another school. Janelle, do you have any insight on that?
Yeah, so that's a great question. So in regards to the lab requirements, I don't have an exact answer right now, but I do remember seeing on the UCSF website as to how they're handling students who don't have the full lab requirements given the pandemic and all the different changes. So I would definitely direct anyone who's interested to that to see what it is, because the pandemic has definitely turned everything 180. Schools are definitely understanding as to what you're able to do or not do, but if there's a chance you're able to still complete it, still please do. In regards to a non pharm sci major, again, I was a public health sciences major, so I didn't have, while I was still at UCI, I still was able to take those labs, but then for the ones that I wasn't able to get, such as anatomy lab, that's again when I took the route of community college, and that's how I was able to fulfill that. And then I think another thing too with UCI, I'm not too sure with the given pandemic, but there's also taking classes in the summer as well to get your credits.
For those of you whose grades might be a concern, know that the extra classes that you might take after you graduate might be the difference. It was in my case. I had not only to make up some classes, but I needed to prove to UCSF that I had the ability to be successful there, in which case I used those years to help continue to show them that I had the ability to, that my GPA coming out of UCLA was not reflective of my abilities at the time. So for those of you that are concerned about grades, know that you're not stuck with your situation. You have the ability to address your relative deficiencies, whatever they are.
Yeah, I definitely echo that as well. I didn't have that Starling GPA as well. So in regards to not only taking classes I need to fulfill, I also took some classes where I was like, okay, well, I didn't get the best grade on this. I wanted to make sure that I was competent in that starting graduate school. So since I did have like that time before school starting again, that I really made sure to show them that I'm more than my GPA. Like I have all this leadership, I have like, again, all this research, like there's more to me than just that number. And I think too, also the 3-year program at UCSF, they don't even have a GPA anymore. It's pass, no pass.
Hi, Dr. Baje. So I personally don't have a question, but I have a comment. Is that I really want to thank you for coming here to for our meeting again, because for last year's meeting when I was a freshman, I don't think although the quality of the content of what you presented is still really good, I don't think I got as much as I wanted it today, because when I was a freshman I didn't have much of an understanding in what the field, the diversity of the field, or on the and all the hospital setting, all this kind of stuff. So, but for now, coming into this year, I feel like I get a lot more from what you presented, and I can actually imagine, imagine your work, and how you administrated things. So I would like to thank you for coming again.
I appreciate that. Yeah, for me, I think I started out with this question of what is it that inpatient pharmacists do? So if you've painted a picture in your mind, hold on to that and value then that you spent the last 60 minutes learning something you didn't know. But why is that important? In which case, think about the interview that you might have for pharmacy school and being able to speak intelligently about inpatient pharmacy and some of the roles. I mean, a lot of the questions may circulate around kind of figuring out how much do you know what you're getting into. You know, the age-old question of why do you want to go into pharmacy? You know, why not nursing? Why not physical therapy? Why not, you know, something else? And if you're able to speak about the things that you learned tonight, and if that excites you and you convey that excitement, then that may actually may benefit you. So the most I can ask is for you guys to at least come away feeling like you're a little bit smarter today than you were maybe 60 minutes ago. And if you have this picture in your mind about what pharmacists do, then I've been successful in what my goal was, which is to make sure that you got a sense of what this entails. And it's not any one thing. You can see it's a lot of everything. And if that excites you, then yeah, maybe you're on the right path here.
Okay, so we have time for one more question, if anyone has a question.
Oh, so just thinking about if we can imagine what the inpatient pharmacy is doing. So can you tell a bit more the specific routine that he's doing every single day, or is it it's flexible every single day? It depends on the patient case that you receive or something like that.
Well, again, that would be specific to whatever position that you are and what areas that you're covering. So obviously what you do every day in an IV room, for instance, would be different than what you would do in kind of the regular main pharmacy. What you do as a clinical coordinator each day is markedly different than what you do as a critical care pharmacist every day. So we would have to kind of identify specifically, you know, what area you're interested. But if we're talking generically, then, you know, orders get put in and ultimately pharmacy needs to produce those meds. Meds are going to be ordered on patients up on the floors, and somehow pharmacists are going to have to pass judgment on those meds. We're not merely facilitating the ordering of meds. We're standing between the prescriber and the patient, and we're passing judgment for all those decisions that are being made with respect to drug therapy. Maybe we have a hand in what is being prescribed or what is being changed. But the essence of pharmacy is not just how do we get the meds out as fast as we can. It's, is this an appropriate medication to use? Is there a better one? Is this the safest one? What does the evidence show? How much does it cost? Does it interact with other medications? Lots of considerations. So in its rawest form, right dose, right route, right frequency, that's the core. And again, that goes beyond inpatient pharmacy. That's what your retail pharmacists are doing. Thank you, everyone. And for anybody who's interested in who has any additional questions, I'll probably stay on for just a few more minutes afterward. And we'll see if Janelle is able to stay on as well, though. With good luck to you all. Make the most of the current situation. Don't use it as an excuse for this or that. Adapt, overcome, continue to excel, and we'll get through this.
Alrighty, thank you so much, Dr. Baje and Janelle, for coming to speak to us today. I'm sure we all gained a lot of knowledge and insight on inpatient pharmacy, and I see everyone's already applauding. Can we get a round of applause, everyone? All right, so that concludes the meeting, but as Dr. Baje said, if you have any additional questions, feel free to stick around and he will be able to answer them. Thank you everyone for coming today.